Very good evening to everyone, and welcome to today's webinar hosted by the Department of Pathology, AIMS, New Delhi, under the name Under My Scope on appendiceal pathology, not always vestigial, by none other than our alumni, Dr. Rifat Mannan from the City Hope National Medical Center, California. I would like to invite our chairperson and the head of the department, Professor Manoj Kumar Singh, to formally introduce Dr. Rifat. Sir, please.
Right. Hello, everybody. Dr. Abul Allah Sayyid Rifat Mannan joined this department in 1998, January, after doing his MBBS from Assam. And he was with us for 3 years. And I must tell you, he is a very lucky person, because just as life started giving him stones, he found, some gold out of them. So those were the good old days when the students used to choose their own guides and thesis areas. And Rifat, unfortunately, chose a topic in skin, and he was mentored by two eminent dermatologists and a pathologist. And Rifat had a really tough time doing his thesis, because he was running to Safdarjung Hospital and maybe a couple of other hospitals to get samples. And he did electron microscopy, and he had a tough time doing his thesis. But it came out as something which nobody had ever done. And he, in fact, had trouble finding references for his thesis, because he worked on in post-Kala-Azar dermal leishmaniasis. There are hyper and hypopigmented lesions, and the hypopigmented lesions are not disease. Nobody knows why they occur. So Rifat did electron microscopy in those, and he had a tough time, but came out with an excellent piece of work. And these his mentors, the dermatologists and the pathologists, kept on kind of chasing him while he was preparing for his final exam, and were trying to convert him into a dermatopathologist. But he did the clever thing. He did his exam, passed his exam, and then ran away. So, and then, of course, you many of you are familiar with his with the work he has been doing. He's specializing in gastrointestinal pathology, and was on the East Coast, currently in California. And he is very famous for the teaching webinars that he's the site that he has co-founded, and is very well known in the world of pathology for that work. And obviously, in the past year, he has not been able to come and visit us, but we are looking forward to hosting him sometime, whenever God and Corona permit. Rifat, over to you.
Dr. Rifat, you can start now.
Yeah, can you hear me?
Yeah.
I don't see myself yet. Okay. So thank you so much, sir, for your very kind introduction. And it brings back so many good memories as your student in at AIMS. So, and you're right that I was lucky to have chosen you as my guide, and actually um, my passion was dermatology at that time. After uh, I left actually medical college, and I had the opportunity to work in the Department of Dermatology at AIMS with Dr. Ramam and others. And I was just a houseman and doing some work. So then I thought that maybe I would do dermatology in the future, but that did not happen. And then I joined pathology. So it was still the same institute. So I thought that, okay, maybe I should at least do my thesis in dermatopathology. And that's how I didn't have to think much. And Dr. Manu Singh sir was, of course, the only person at that time. And I chose him as my mentor and guide. And Dr. Ramam was my co-guide. And as Dr. Manu Singh sir said, that it was a topic I really learned a lot during that time. And thank you for your kind words, sir. And I think I learned a lot. And though I had to, it was a prospective study. So that's why, like, post-collagen dermal leishmaniasis patients were not too many. And that too, the hypopigmented lesions, the patients with those lesions were not often seen. And I was lucky actually, it was because of Dr. Manoj Singh sir. So he partnered me with Dr. V.K. Ramesh. So he was at Safdarjung Hospital. So he is very well known for his work in post-collagen dermal leishmaniasis. And also he partnered me with Dr. Ashok Mukherjee sir at the Institute of Pathology across the street. So I used to go to both of them, and some patients were of course from AIMS as well. So it was a really good experience. I think that I enjoyed it. And as Manoj Singh sir said, that we did electron microscopy at that time. So that was a really good learning experience for me as well. So no, I have very good memories, and it's really good to have Dr. Manoj Singh sir uh, introducing me today. And I'm really lucky to be here today and uh, getting invited. And thank you so much, sir. And thank you everybody in the Department of Pathology for considering me to be here today. And I am, as Dr. Manoj Singh sir said, that I enjoy organizing webinars, and we have been doing it for last 5 years, me and my good friend Amelia. We enjoy doing it, but being on the other side on a webinar is not much that I do. So it's a little different today. So I hope you will like the topic. So without much ado, I would like to start my talk. Is there anything that needs to be said? Anything there? Prasenjit?
No, you can go ahead, sir.
Okay, thank you. So I will share my screen, right?
Yes, please.
So I have chosen this topic of appendiceal pathology. I think that there will be residents and trainees today who might be logging in, and thank you all for today. We are actually in the world of, we have all become virtual, unfortunately or fortunately, but the good thing is that we are connected. I mean, somehow the virus has connected the world more than we could imagine. And just like, I mean, it gave us a new perspective of life, I would say, because like all these technologies were existing before, but somehow we were not using it much. Like Zoom was there, Google Meet was there, but just because of the pandemic, we have started using it so much. And today it's almost 7 a.m. in California, and I am talking to other part of the world. People are there, and it's like 7:30 in India, I think beyond 7:30 now. So I thought that I would touch this topic. I love the appendix myself, and uh, because there are a lot of trainees, I thought they will be here today, and maybe some people like who might not be doing GI pathology per se. So appendix has an organ. I mean, as we have always learned of in medical school or medical colleges that, oh, it's a vestigial organ. That is how we have always heard about it or talked about it. And most of the time, like, I mean, acute appendicitis, all of us had probably at some point. I also had a tough time with acute appendicitis, and I almost perforated it, and I had an emergency surgery at some point. My daughter had acute appendicitis. She had to get operated, I mean, on an emergent basis. So many of us had it. And in pathology world, I think when we have the slide of acute appendicitis, basically it is like maybe less than 5 minutes, probably. Let us be honest about it. We spend, oh, it's acute appendicitis, the next slide. But it's not always so. And what is important is that, and especially for pathologists, majority of the appendices that we receive in the lab are sent as acute appendicitis. Majority of them, they just come like that. And even though there are myriads of pathologies, most of the time, the patient presents with pain in the right lower quadrant and diagnosed as acute appendicitis. They do not have specific radiologic findings or clinical findings based on pathology types. They just come as acute appendicitis. And in pathology lab also, we get the specimen like that. And most of the time, we will see that there is no specific gross pathology on the grossing table. So we do not know exactly, like, when we are grossing it. Unlike others, it's a small organ anyway. And I mean, if we are lucky, like, we might see a pathology grossly, but most of the time we will not be lucky. And it's a tiny organ, so it is coming as acute appendicitis. We take it three sections, maybe in one cassette, and let it go. But yes, as we will see today, that, and we know, and those who are doing GI pathology, Prosenjit will know, and others who are doing GI pathology, Rajni will know, that there are a lot of lesions in appendix which we see every day and which are of importance. This is my institute now, which I have recently joined. This is City of Hope Medical Center. It's a cancer center, it's a very old institute, which was founded in 1918. And it's the nice scenic view of the St. Gabriel Mountain at the backdrop. I hope, so let's talk about appendix then. And as you know now that it actually harbors a lot of pathologies, which is both neoplastic as well as non-neoplastic. Some of these pathologies are obvious, and some of these are very incidental findings. So it's important for us to keep an eye for those pathologies which are not so obvious, because some of the obvious pathologies are like, I mean, acute appendicitis, all the time we see that it's no-brainer. But as pathologists, it's for us to keep an eye on the not so obvious one, which we can easily miss. But if we are just a little bit careful, we would be able to diagnose them. It's just to be aware of that there are other pathologies than acute appendicitis which exists, and we just need to keep an eye on it. Of the different pathology processes that involve the appendix, one important pathology is mucinous neoplasms. So there are different types of mucinous neoplasms in the appendix. Some of these are benign, and mostly benign, and they are malignant as well. The problem for pathologists is that these are very confusing, as we will discuss slowly, and many of you might know already who are doing GI pathology. But these mucinous neoplasms have a lot of clinical implications, which are very significant prognostically. Of course, you guys know it. So that's why the correct diagnosis is very important as far as treating the patient is concerned, especially in those instances when mucinous neoplasms are coming. So, and as we have said, that most of the things like in appendiceal pathology, those are incidental, and they do not have a specific gross pathology, or they do not have specific clinical findings. So it's on us actually as pathologists to hunt for them. So we did a study when I was a resident at Mount Sinai in New York about what are the incidental findings in appendix. We just quickly looked at 1-year data. And in fact, in these few specimens, we found that in around 13% of the specimens, there were a lot of incidental findings. And all these, actually, we excluded appendices which came as part of colectomy specimens. We just included only patients who presented as acute appendicitis, and there was nothing clinically suspected. And in fact, we found a lot of different pathologies. just to give an idea that there were mucinous neoplasms, and it was 2017, so there were different names. Some were diagnosed as mucinous cystadenomas, some were called lamin. There were neuroendocrine tumors, different types of polyps, as we will see that polyps can be seen in appendix, similar to colon. There were goblet cell carcinoid, and as many of you know who are doing GI pathology, that there is a new terminology for that. It's not called goblet cell carcinoid anymore. So there were adenocarcinomas, and in fact, metastatic adenocarcinoma was also found. Of course, it was one case, but still it was there. And there were so many other conditions that we found, like endometriosis, diverticulitis, granulomas, actinomyces also, and melanosis. So just a brief idea that even though we are unaware, there can be a lot of different pathologies which can be there in the appendix. And as pathologists, whether we are doing general pathology or GI pathology, it's just important. And those who are students who are learning pathology, it's so important for you to not to ignore the appendix. And if you are grossing the appendix, just be a little careful. And one thing I would like to say for the residents or trainees who are grossing appendix or wherever they are, that always ink the margin, always ink the base of the appendix and submit it. Because if it is a tumor, for example, a mucinous neoplasm, then surgeons would like to know the resection margin, and you are required to comment on the resection margin. And for appendix, the resection margin is obviously the base of the appendix. But if we do not submit the base of the appendix at the first time, then we can, unlike other organs, we cannot come back and find which was the base of the appendix, right? So that's why it's very important that whenever we gross the appendix, better to ink the base of the appendix and submit it anyway as a routine. It just takes 1 extra minute, and we can submit it so that it becomes a habit. And if we find something, we always have the base of the appendix. And 90% of the time, like here, we will not find anything, but still it doesn't harm us, that we won't do anything wrong by just inking the base of the appendix. And we don't need to make a separate cassette for that. If we just ink the base of the appendix in one of the sections and always submit that base of the appendix, and that should be enough, I think. So the objective of today's talk for me is that I want to share a few examples of appendiceal pathology, which I have come across, and some of the cases which my colleagues have shared with me. And these are both non-neoplastic as well as neoplastic. And I would like to place special emphasis on mucinous appendiceal neoplasms, which has gone a change regarding nomenclature and all after the recent WHO classification of digestive system tumors, that is 2019. So I want to focus more on that regarding classification of the mucinous appendiceal neoplasms, what are their diagnostic criteria, what's the clinical and prognostic significance of those entities. And there are a lot of neoplastic mimickers of those mucinous appendiceal neoplasms. So as pathologists, we need to be aware of those neoplastic mimickers. I want to highlight a little bit about them so that we don't underdiagnose or overdiagnose neoplastic lesions in the appendix. And there's a new terminology, or we can say that the new kid in the block, or maybe that old wine in a new bottle, if you want to say that. So this is a new terminology in the new WHO classification of an entity which was previously known as goblet cell carcinoid, but now it has been renamed as goblet cell adenocarcinoma, which I feel is quite relevant. So I will briefly touch upon that as well. So this is what is my today's objective. And if there is any question anybody has, please feel free to stop me. I would be happy to take your questions and try my best to answer them. So let's start with inflammations. So I have a few digital slides, so I will go back and forth between the slides and discuss a little bit on the entity. Hope that will be okay. So before we start with pathology, and I presume that there are students here, so I want to just quickly take you to how the normal appendix looks like. And of course, just a refreshing you. It's not that we all are aware of it. So I have got two images here, as you can see. So this is just how a cross section of the appendix you will have, because majority of the time you won't find any pathology, right? And it is just a benign appendix. I was lucky to have a section here. So as you can see here, so I'm just trying to refresh you and just to keep you aware that how things change in the appendix. We have this nice cross section with a lumen here, and you have this lymphoid aggregates, so that's okay. But what I want to show you here is look at the lining. So this is the lumen, and this time it is not distended, so the patient didn't probably had an obstruction. So we have the epithelium here, and also keep an eye on the crypts. So you have the crypts here, right? So, and at the same time, so that means this is normal. And keep an eye on the lamina propria. So we have the nice lamina propria in a normal appendix. So that is what we see in a normal appendix. And sometimes when the appendix is dilated, of course, the appendix is often dilated because whenever there is a ficolate, so which actually leads to an obstruction, so that there will be ficolate in the lumen on the right side of this image as we see, and it will be a dilated appendix. So once it is dilated, let me go back to this. So the lumen is no longer as narrow as it is. So just to keep, basically it's simple physiology. Sometimes we forget when we are looking at the slide. I mean, we start thinking of a lot of things. So it's just dilated, as we can see in this image, but still it has the same structure. And if you go zoom in, we will see that we have the same epithelium here, just a little different than this because the lumen is dilated, and it is a bit atrophied, right? For no other reason, but just because it is distended and dilated. But still it maintains the same histology, as we can see that you have the epithelium, which is columnar, and you have the crypts. So remember these crypts, they are your friends. So that means if you remember the crypts here, that means that, oh, this is probably, it's not neoplastic. And another friend that we need to keep always in mind while evaluating an appendix is the lamina propria. So here we have a nice lamina propria, but even in a dilated appendix, it's the lamina propria is nicely maintained. And as we will see that presence of lamina propria is an important histologic finding that actually helps us in differentiating appendiceal neoplasms from other or non-neoplastic entities. So just a brief reminder of how we should look at an appendix, and let's delve into the cases. So inflammatory conditions. There are a lot of inflammatory conditions. Of course, the majority of this is acute appendicitis, so I don't want to go into that. So 90% of our cases will be acute appendicitis and periappendicitis. Sometimes it is perforated, sometimes it is not. Sometimes the perforations has healed. So that's all we are going to see. But I'm not going to share those cases. So let me show you something that sometimes we get to see as well. So here is an example of an appendix, which looks a little different, as you can see. It's little like, we can see that it's fibrosed. The wall is very much fibrosed. And another thing I want to bring to the attention of especially the trainees is that whenever you are looking at the slide of the appendix, usually there will be multiple sections. Let me show you. It is obvious, right? There will be 4 or 5 sections on the same slide. So let us not forget that. And we should make it a point to look at, even though the patient had just acute appendicitis, it is slam dunk, just make it a point to look at all the sections, because maybe you have a pathology lying in some section while the other sections are not showing anything. So now coming back to this case, so there is a lot of fibrosis, as we can see here. And again, a lot of fibrosis. The second thing that is obvious here is lymphoid aggregates. We can see these lymphoid aggregates, which we do not see often, right? In an appendix. And again, here in this section, we also see a lot of lymphoid aggregates, but there is a location of these lymphoid aggregates which we should focus on, is that outside the wall. So it's like a string of pearls that you can see, that which is very characteristic of this entity. So keep an eye on this, that of why these lymphoid aggregates are arranged like this. And some people also like to call it Crohn's rosary, because it, what is that called? It resembles Crohn's disease as well, when we see something like this. So whenever we see an appendix like this, so we should keep an eye on that, what else might be there. If you see here, so now I'm zooming in, so there are nice juicy granulomas, right? So this is a non-necrotizing epithelial cell granuloma here. And there are a lot of other granulomas, small ones, like which are there in this specimen of appendix. So the diagnosis is quite obvious. So this is a case of granulomatous appendicitis. So, but granulomatous appendicitis per se is just a pathologic diagnosis, right? And it's not it's a pathologic pattern, you can say. It does not give you the etiology. So there are a lot of associations with granulomatous appendicitis. Sarcoidosis is something we will always keep in mind, and many infectious conditions. And of course, when we are in India, so we should always definitely keep Mycobacterium tuberculosis in our mind, which might or might not give necrotizing granuloma. So another organism to be kept in mind which gives rise to granulomatous appendicitis is Yersinia. It can be fungi, parasites. I want to put special emphasis on actinomyces also. In fact, why? There was a nice paper in 2019 written by Dr. Misraji, who is very well known in the field of appendiceal pathology. And he described, and their group described nice, a lot of cases, I think 20 cases maybe, of actinomyces causing granulomatous appendicitis. This is a very nice paper, so you should look at it. And how that paper is actually describing how to differentiate actinomyces causing granulomas from other causes of granulomas. So again, Crohn's disease. So in the Western world, everybody is aware of Crohn's disease, that it gives rise to granulomatous inflammation, and appendix can also have granulomatous inflammation as part of Crohn's disease. But Crohn's disease involving appendix alone is not very common. So usually those patients where we see granulomas involving appendix, they will also have Crohn's disease elsewhere. Only in less than 10% of the cases, I guess, I don't remember the exact percentage, you have Crohn's disease only involving appendix. That's very rare. But another entity that we forget, and I want you to pay special attention, is that interval appendectomy. So let us talk about that. So today what we saw in that case is that we had transmural lymphoid aggregates like here and some granulomas, right? So interval appendectomy is becoming more and more relevant nowadays because many patients who present with acute abdomen or have perforated, they are managed conservatively when they present at the ER. So they are managed with antibiotics, and then later appendectomy is done maybe like few weeks later. And when we get those specimens of interval appendectomy, the histology is different because the lesion has healed. Maybe there was an acute appendicitis which is perforated, but now it has healed and we have something different. And the histology looks different. And many a times the histology in interval appendectomy specimens mimic Crohn's disease. And this was a paper, it was an old one, but there are a lot of new papers as well which describe interval appendectomy and histology. And the histology in these specimens often mimic Crohn's disease. We will have granulomas, transmural fibrosis, transmural lymphoid aggregate, and like the string of pearls or Crohn's like rosary, like we see here. So this we see in a lot of entities, and including interval appendectomy. So keep an eye on it. That not to forget that this can be a cause of granulomatous appendicitis, and we just need to. This is the time that we pick up the phone and have a word with the surgeon, or if we have access to electronic medical records, so we can look at the patient's notes, so we will know that the patient probably had, the acute appendicitis presented like a few weeks back, and they are doing a surgery at this time. I just want us to be aware of this and not to forget that as a cause of granulomatous appendicitis. Let's go to case number 2. So again, another appendix, and all these patients have no other history, just acute appendicitis, and that is how the specimen came, and there was no specific gross pathology. So here again, so this is one section of the appendix, the lumen is obliterated, which happens often. But in this section, we already see that there is probably like periappendicitis, right? So we can see outside there is neutrophilic inflammation, so that is fine. But what I want to show or bring attention are those epithelial elements. So basically, these are like benign epithelial elements which has protruded outside with the perforation. So what I want to emphasize is that the moment we see epithelial elements outside of appendix or outside the appendiceal wall, we should not immediately start thinking of a neoplastic process. If you remember that just the appendix and how the physiology happens in appendix, or what pathology happens when patient has acute appendicitis, just we should keep that in mind. If it perforates, you can always have epithelial elements which will perforate through the wall of the appendix. So that does not mean that this patient has neoplasm and this is neoplastic epithelium. But in this particular case, I want to bring attention to another finding here. So this is the other section. And as I said, again, for the trainees, always examine all the sections that are on your slide. Just don't say that it is acute appendicitis and move to the next case. So here we see that this is not a problem. There are some glands here, right? I mean, which should not be there. So your lumen is here, epithelium is here, but why we have some glands on the periphery, right? And this is one example. We are not supposed to see those, right? And as you can see that these glands have very classical morphology, right? We have cuboidal lining maybe and little bit of cilia here. And there is something very characteristic about it. There is something here. And whenever we see it, of course, you know the diagnosis, I'm sure that this is endometriosis, right? So basically just to keep you aware that you can have endometriosis in the appendix. But if we think that this was acute appendicitis alone, so we can easily miss it. It's not a difficult diagnosis, but again, it is just to be aware that, hey, we can have endometriosis involving the appendix as well. So that is that. But I have another case of acute endometriosis I want to show you. It's not always that obvious. For example, this is another example of endometriosis. Why I want to share this case is that, so again, there is nothing much happening here. Let us go to low power. But this case actually was brought to me when I was at Penn by my trainee, one of my trainees, saying that, hey, there is something interesting in this appendix. I said, okay, what is it? So I was told that I think there is a tumor. This patient has tumor. So I saw there are some glands outside. So maybe we should look for tumor. I said, okay, let us look at it. So then when we look at it, see, this is how the so-called tumor looks like. And it is obvious that, again, this is very classical of endometriosis involving the appendix. So we have the nice endometrial glands and the stroma. So why I'm saying is that he was not wrong. So he was good is that he could diagnose that there was something going on. But I mean, we don't see them often. So that's why it's so important to be aware of that endometriosis can also involve the appendix. And if we are a little bit alert, then we will be making the diagnosis because it is like endometriosis elsewhere. So we don't need any immunostain to prove or diagnose acute endometriosis involving the appendix. But if you want to be a little bit fancy, so we can do a CD10 stain, so which will highlight the endometrial stroma like here. So this is CD10 highlighting the stroma. And if you are still not convinced, so maybe we can throw in a Paxate as well, just to make sure that, oh, these are of a Mullerian origin. So this is just showing Paxate highlighting these cells, but we don't in clinical practice need immunostain to make a diagnosis of endometriosis. But sometimes endometriosis is complicated when there can be intestinal metaplasia involving endometriosis. I don't have an example to show, but there are a lot of good papers from Yale and other places. Dr. Dhanpat Jain had a paper on endometriosis with intestinal metaplasia. So you should keep an eye on that because sometimes when you have those, that can mimic low-grade appendiceal mucinous neoplasms as well. So endometriosis in the appendix can also come in various flavors. So we just have to be aware of them as well. So moving on, infections. So we can have different infections involving the appendix. I want to show one example of that, a couple of them. And again, there is no specific history here. It's the same history, acute appendicitis. And there is no specific gross pathology as well. Let's look at this slide. So here, I will go to low power. So we can see that there are again 3 sections. So I'm just trying to highlight to the trainees that, hey, look at all the sections. So there is nothing happening here. Sorry, this is blurry, I think, because at low power. But here we can see that there is something happening. And the wall is totally fibrosed. I would try to be slow so that there is no pixelation, so that there is no lag. So it's very fibrosed here. So that means there is something wrong, which is very unusual, right? And it's like hyalinized fibrosis, and maybe there is some calcification here and there. I have highlighted few of these. So let us see what are those. If you go to high power, so we can see that there is something, looks like some calcified, looks like a spine here. And there is a group here, so where we can see something going on. So this looks like some something here as well, and all this. So if you know, like, because this is appendix, so maybe that diagnosis is not coming to the mind quickly. But if it was a specimen from the bladder, urinary bladder, and if I say that this patient is from Egypt, so you will probably think immediately that, oh, I know what is going on. So what's the diagnosis? And I'm sure that many of you have made the diagnosis already, even though it is appendix, that these are actually calcified or like fibrosed larva of what's it called, cystosoma. So this is schistosomiasis involving the appendix, which is very uncommon, but you can have it. And in fact, this patient was an elderly gentleman who was from Egypt. So, and that is an endemic area for schistosomiasis, as we know. So schistosomiasis can involve rarely appendix, and we don't have to subspeciate them like hematobium or japonicum, but if we can make the diagnosis, that is good enough. And you can sometimes have schistosomiasis in the appendix as well. Let's go to case 4, another infectious condition, which is probably more commonly diagnosed in the appendix. And I think many of you have seen it. And I think in India, we see it probably more often than not. And again, for the trainees, I want to emphasize that how many sections you can have on the same slide, right? And sometimes your pathology is not on all the sections. Like here, for example, so this one is good, nothing is happening. So there is nothing happening here. So this is okay too. But if you keep moving, we see that there is something inside which should, make you a little alert. And again, so don't forget the lumen. That's what I want to emphasize, that sometimes your pathology might be lying in this tiny lumen as well. So it's just to be aware of it. And let me zoom in. So what is happening here? And as you can see that this is very classical. I don't need to ask this question that what is this? So when you see something like this, so it's a very classical of the parasite Enterobius or pinworm, right? And pinworm has this very classical morphology. And if you see it one time, nobody is going to forget it. It has this lateral spines known as lateral ala, and you can in fact here see the cysts or the larva as well inside. And I want to thank my friend, Dr. Arman Kararjian. He gave this slide to me, and thanks to him so that I am being able to share this case with you. So this is Enterobius involving appendix, and not very uncommon. So let's move the gear from different infectious and inflammatory conditions. There are a lot of other parasites which can be seen. I'm sure many of you have seen. And as that I mentioned about that paper about actinomyces involving the appendix. So I have not seen one, but there you can have actinomyces and other parasites or other organisms as well. Tuberculosis can involve the appendix. Definitely many of you have seen. But I just wanted to give an example that just to keep an eye about the different things that you can have. Regarding neoplasms, so I want to start with a common one, which we see often. And again, it can be often an incidental finding. And the patient will come as acute appendicitis and nothing much. So at low power, here again, we can see that there are multiple fragments here. So one of the fragment is showing fibrous obliteration of the tip, and nothing much is happening elsewhere. And just to highlight that again, that this is an appendix where we have some filiform arrangement and some hyperplastic changes, but still our friend lamina propria is maintained. So this is not neoplastic, right? But I say that I want to show a neoplasm. So this is here in one of the sections from the tip. and it's no brainer. You can see that, oh, there is something happening here. The tip is involved by this lesion, and the diagnosis is not a problem here. So I mean, I'm sure that every one of you can make this diagnosis easily that, hey, this is a neuroendocrine tumor involving the appendix. But what is more important is that neuroendocrine tumor is one of the common tumors that you see in the appendix. But again, this can be easily missed if we are not being little careful. Diagnosis is not a problem, but just to be aware of it. And we can do an immunostain to confirm it, of course, that we can do a chromogranin and synoptophysin and make a diagnosis of neuroendocrine tumor. So this would be a grade 1. And in the new WHO classification also, the neuroendocrine tumors are graded as grade 1, grade 2, grade 3 well-differentiated neuroendocrine tumor, similar to the grading used for neuroendocrine tumors elsewhere in the GI tract. And we can also rarely have neuroendocrine carcinomas like in other parts of the GI tract. So I'm not going into the details about the neuroendocrine tumor today. Let's move into another neoplasm, case number 6. And again, the specimen is the same, history is the same, acute appendicitis. I want to show you this. So this is a low power view. Well, now we can see that the appendix is not looking the same anymore. So we have seen a lot of benign appendix already, but right now this does not look, this looks different, right? So definitely the lumen is distended. Well, that's not a criteria to diagnose a tumor, of course. And we have some mucin in the wall. But what is important here is that what is happening to the lining? The lining looks very different. And let's zoom in. In most of the places, the lining is very attenuated and flattened, right? So it's just a flattened lining, which looks very benign looking. And at some places, it's mucinous. And when the lining is a little bit more maintained or not attenuated, we can see it better. Let me go to one area here, for example. So here we can see the lining better. So this is a little bit of a filiform appearance here. And again, this is a benign looking hypermucinous lining here. So it's a tall columnar mucinous epithelium. But what I want to emphasize here that there is something else. So definitely this is not a benign appendix, sorry, not a non-neoplastic appendix anymore. So the lamina propria, which is supposed to be our friend, is not here anymore. So there is fibrosis of the lamina propria, which is underlying this flattened epithelial lining. So when we see an appendix like this with lamina propria is gone with fibrosis, and then we have the lining which is tall columnar but still low grade mucinous, and our diagnosis is obvious, right? So this is a case of low grade appendiceal mucinous neoplasm, or LAMN as we commonly call it. So I want to discuss a little bit about LAMN and about how it is important for us as pathologists to diagnose them properly. So appendiceal mucinous neoplasms are actually pathologist's nightmare. And there has been so many confusing terminologies over the years that we as pathologists have also not helped ourselves. And it has led to a lot of confusion. And that's why, and there are so many terminologies existing. Some people call it mucocele, maybe it's called as a retention cyst. And there was an entity called mucinous adenoma till the last WHO classification. Now it has been not there anymore. And then we have LAMN and high grade or HAMN as well. So there are so many terminologies and it's very confusing for us. So that's why the new WHO classification made an effort to actually give it a direction, I would say. And the appendiceal epithelial tumors are classified like this in the new WHO classification. So there can be hyperplastic polyps, like what we see in the colon, sessile serrated lesions, similar to colon, right? Then we have low-grade appendiceal mucinous neoplasm, which is by far the actually most common appendiceal epithelial neoplasm, and which is important for us as pathologists to know and diagnose. And we can also have rarely high-grade mucinous epithelial neoplasms, which are called HAMN, and adenocarcinomas. of which mucinous signet ring cell. So this is basically the new classification of epithelial tumors of the appendix, and goblet cell adenocarcinoma. As I said, that this is the new kid in the block, and this is the new terminology in the 2019 WHO classification. So talking about Laman, and as we saw in this case, that this is a mucinous epithelial neoplasm with low-grade cytologic atypia, and we can have villous epithelial proliferation, or sometimes it can be undulating. But the absence of normal lamina propria and the lymphoid tissue will be helpful in making the diagnosis, as we saw. And I will share a couple of more examples of that. And something which to be kept in mind is that it can have a pushing pattern of invasion. And the mucin can actually push through the wall of the appendix, and it can lead to rupture. And that's where the problem is. When in a lamen, there is mucin which is going outside of the appendiceal wall, and then it goes into the peritoneal cavity. That's where the problem lies, because sometimes you can have mucin alone, or it can carry the neoplastic epithelium with it outside of the appendix. And sometimes maybe it can be confined to the vicinity of the appendix, then it is fine, but it always has the propensity to disseminate into the peritoneal cavity. And as we all know, that this can lead to the catastrophic clinical consequence of pseudomyxoma peritonei. We will talk a little bit about it. So that is why the reason is why we need to diagnose Laman. Though it is low grade, diagnosis is not a problem, but it has a lot of consequence for the patients. If it perforates, it can lead to pseudomyxoma, and that's not a good disease to have, and that is not easily treatable as well. We will talk about it soon. So similar to Laman, there is also high-grade appendiceal mucinous neoplasms that is in the WHO classification. It has the same criteria like Laman, but it will have high-grade cytology of the epithelium. But Hamans are very rare, but because again, most of the Hamans are actually high adenocarcinomas. That's why before we make a diagnosis of Haman, we have to again sample the entire appendix and make sure that there is no invasion. So if we don't see invasion, then only maybe we can make a diagnosis of Haman. I have not seen one yet, and I'm sure many of you might have seen it, but it's rare. So we have to remember that before we call it Haman, sample the entire appendix and make sure there is no invasion. Because if we have to call it a Haman, it has to be confined to the epithelium and without any invasion. So this is a textbook picture. Actually, I've taken it from a book. I have not seen it for a long time. So this is a gross picture of Laman, which is, we can see that this is a distended distended appendix. And if you look at a section, that it is filled with mucin. So this gross picture we can see on this grossing lab often actually. And whenever we see this, I would say that we should tell the whoever is grossing, maybe it's a PA or a student, that take it seriously, that whenever we see something like this, which is coming as mucocil or acute appendicitis, so we should immediately ink the base of the appendix and submit the entire appendix. Here we have to be a little liberal and not conservative. For these, like, we should not have only 3 sections and go. We definitely have to submit the entire appendix and ink the proximal margin for sure. So we will talk a little bit about it. So again, we saw that this is how Laman will look like on histology. We will have attenuated lamina propria, and the lining will be low-grade mucinous epithelium. But there can be different morphologic scenarios of Laman. That is what makes it so important to diagnose as pathologists. Let me show you that. It can come in various forms. So one example is this. So this is a Laman. Again, I will show you a low power view. So this appendix, we can already see that this appendix is dilated and it has an attenuated lining. And if we go to the higher power, we will see that our friend, the lamina propria, is gone, right? There is no lamina propria, there is fibrosis. And sometimes it is so attenuated that we may not find the lining. That is when again comes the importance of submitting the entire appendix to look for lining. So here we see the lining epithelium, which is, if I go to higher power, we will see that this is again tall columnar, and here it is attenuated. But at low power, I want to show you the other fragment, which is a little bit dramatic, right? So here we can see that we talked about the lemon can have mucin extrusion through the wall. So here we see that already we have the mucin which is trying to dissect into the wall. But still, as we see here, that this lamen is confined to the appendix. That's very important. So lamen can be confined to appendix. Yes, that is something that we should keep in mind. So I want to show you that. And there is another, let me show another example of lamen. So this one looks even more dramatic. That this is an appendix which is absolutely dilated, and it doesn't look like what we saw before, but there is the appendix is full of mucin inside, right? And there is the lining epithelium. We can see the lining here as well. So this is still our diagnosis will be lamen. So this is just two examples of it. I just want to show you side by side. Oh, sorry about that. So we have something like this here. We have something like this here, but both are actually lamen, examples of lamen, which are still confined to the appendix. That is something very important to keep in mind, that if whether your lamen is confined to the appendix or not. So this is one scenario when lamen is, and as we saw in this case, when lamen is confined to the appendix. So that is something we should know, that when it is confined to the appendix, this should be staged at TIS. We will talk about the staging of the tumors of the appendix as well, or lamen, staging of lamen. But not all lamen will be confined to the appendix. Let's go to the next case. If we see here, for example, this is another example of lamen, yes. So we see that the lumen is full of mucin, and we can see the neoplastic epithelium here lining the wall of the appendix. And this is the luminal side, of course, right? And here this epithelium is more undulating, more villiform as compared to the examples that we saw before. But still, the diagnosis is not a problem. It is lamen, and we can see that the important diagnostic hallmark, the lamina propria, is gone. So there is no lamina propria which is fibrotic. So this is definitely lamen. That's not a problem. But what is problematic in this patient or in this specimen is the presence of mucin outside. So you can see that not in this section, like here only we see that the mucin is outside. We don't see the point of perforation in this section, but definitely the mucin has gone outside here of appendix, which is very important for us as pathologists to know. But not only mucin, there is also neoplastic epithelium which has gone outside. So this is another scenario when you can have lamen which has ruptured, and along with the mucin, it has carried the neoplastic epithelium. These are the patients which are at high risk of developing pseudomyxoma, and that is where it is so important for us to submit the entire appendix for histologic evaluation, because in other sections, maybe we did not see the point of perforation and it was still confined to the appendix. So we would call it TIS. If you only examine two sections and we get a nice diagnosis, and we will call it lamen TIS and next case. But that's why whenever we see an appendix and we think that this is lamen, so the next thing that we must do is to submit the entire appendix, so that we might be able to find areas like this. And not always it will be that dramatic. It can be only focal area of mucin which is ruptured, right? And that still will be prognostically important for the patient. So let me keep it here so that I can show another one. So this is another example of lamen which has perforated. So this is a low power view. And we can see that here again, this is the luminal side and it's attenuated epithelium. But the problem is here also there is a lot of mucin outside which is perforated, and along with the perforation, so we can see neoplastic epithelium. So these are two classic examples that this is the second scenario in which we actually have lamen which has perforated, and carrying with the perforation, there is this mucin which is outside. So this is second situation when we have perforated lamen along with mucin and extravasated neoplastic epithelium. And what is important here is that these cases, when lamen has ruptured, the staging has increased. So it should be staged as PT4A according to the AJCC 8th edition. So that's something very important as pathologists so that we correctly stage them. Let's move to case 9, which is again a different morphologic scenario of lamen. I'm just trying to show the different scenarios how lamen can present. So let's go to low power. Sometimes this is real world actually, this section. That's why I am showing this case. Not all sections will be as nice as we saw in the other examples. Many a times because it is grossed as acute appendicitis. So all sections will be fragmented and we will see here. So now the problem for us is that we know that this is lamen. The diagnosis is not a problem here. We see that our friend lamina propria is gone and it is lined by this low-grade mucinous epithelium. So that is okay. But now as we know that what's the problem is that the diagnosing lamen is only the first step. The next step as pathologists is that we need to stage it, whether it is confined to the appendix or it has perforated. We have submitted the entire appendix, that's great. But what about this? How do we know whether there is mucin outside or not? So here there is mucin, and now we have to use some judgment that whether there is mucin has gone out or not. So this mucin is inside, but there is something here, we don't know what it is, right? So let us keep looking. In the other section, again, this is the outer side, right? And this is the inner side. So definitely this is not perforated, that's fine. And on this section, so this seems to be the luminal side and this is the outer side. So this looks okay too. The mucin is still inside. But keeping moving here, so in this other section, now again to orient ourselves, this is the luminal side and this is the outer side. And if you keep moving here, this mucin seems to be on the inner side. But here, there is mucin outside, right? So we can see that there is mucin outside, and you can take my word that we have examined the entire appendix, and this is the best we could find in this particular specimen. And we have only mucin which is perforated outside, so that is, this is mucin outside the wall of the appendix. Now someone can ask that, well, what about if this mucin was actually artifactual? Maybe like when somebody was grossing, this mucin can always be outside, right? I mean, it can be just during the procedure, it can happen while grossing. How do you do that? That's always a problem that can happen. Then again, we have to use our judgment, look at gross findings, maybe if the grossly the appendix was perforated or not. And if it was intact, then maybe like that will help us. But histologically also, if you look at this here, see that this mucin is very much adhered to the wall of the appendix. It's not floating. If it is floating, then it is more likely that this was just displaced during grossing. But if it is attached like this, here we can see that, and we can see fibrosis in between. It is more likely that this is real mucin which is extruded after perforating the appendiceal wall. So that is important to keep in mind. And when we see something like that, so our diagnosis should be lamen with rupture and extravasated acellular mucin. And this should also be staged as T4A according to most recent WHO classification. So let me show you something here. Why we need to diagnose the lamen. The next case. So this is one of the patients who had tumor in the appendix and which was called a lamen, and now presenting with distended mucin and everything. And this section is taken from mucin inside the patient's abdominal cavity, and there is a history of lamen before. So now here we can see that this is from the mucin pool that was submitted for gross from the abdominal cavity in this particular patient. And we have mucin and along with neoplastic epithelium. So the diagnosis is not a problem. And this is low grade, right? So we have low grade cytology here. And we have submitted multiple sections and still there is only low grade morphology. So this is mucin with low-grade epithelium, which is outside of in the peritoneal cavity. So the diagnosis is not very difficult. So this will be pseudomyxoma peritoniae. And that is where the diagnosis of Lemon is so important for us. So the patient can develop pseudomyxoma peritoniae if it has perforated, and the pseudomyxoma can develop later, and which has a lot of consequence for the patient. So it's a unique disease and which is quite complex. And we know about it that most of the cases of pseudomyxoma are usually derived from appendiceal mucinous neoplasms. And that is why, as pathologists, it's on us to make the correct diagnosis of Lemon, because we can then predict that if these lesions are going to progress to pseudomyxoma in the future. And most common cause of pseudomyxoma is these appendiceal mucinous neoplasms, which can be Lemon or which can even be adenocarcinomas as well. And rarely pseudomyxoma can also happen because of other tumors at other locations. But the problem for the patient is that this is a very relentless disease and with very bad prognosis. And there are a lot of treatment options and which are very aggressive. And one of the most accepted treatment that is used for pseudomyxoma is cytoreductive surgery with HIPEC, which is called HIPEC, that is for hyperthermic intraperitoneal chemotherapy. As the name suggests, that it's a very aggressive form of treatment and it does not serve the patient well. Most recently, a newer form of therapy has been started, which is called PIPEC, that is pressurized intraperitoneal aerosol chemotherapy. And that's also used for patients with pseudomyxoma. And in fact, my current institute, City of Hope, is one of the pioneers of this therapy. And there are a lot of trials going on in our institute for treating patients with pseudomyxoma with PIPEC. And many of these patients had actually Lemon before our appendiceal adenocarcinomas. And one of my colleagues in surgery, Dr. Mustafa Rauf, if you Google him, you will find him that he is doing a lot of pioneering work on PIPEC therapy for pseudomyxoma peritoniae. So it's a very aggressive disease. And as pathologists, it's on us to make the correct diagnosis of Lemon and make the prognostic significance. And so what is our role and how do we report Lemon? We just cannot just report it just like that. So before that, we need to know what is the staging. As we saw that this is the AJCC staging of Lemon, which is different from mucinous adenocarcinoma. So if the Lemon is confined, we call it TIS. And if it is invading the peritoneum, then it is T4A. Whether it is acellular mucin or it is mucin with neoplastic epithelium, so this is called T4A. So that's why that staging is important. So we just not only have to make the diagnosis, we should also stage it, whether it is TIS or T4A, that is prognostically significant, right? So how do we report Lemon? Let's talk about scenario one. So for example, most of the Lemon will be confined to the appendix, just like this. So we should call it as Lemon confined to the appendix and write a note. I personally feel that we should definitely write a note when we are reporting appendix Lemon, because that is what is our role as pathologists, to make sure and communicate with the surgeon that do we see that this patient has increased chance of progressing to pseudomyxoma peritoniae, because they're aware of it. So we should write a note that this Lemon is confined to the appendix and we will stage it as TIS, and such lesions have very negligible risk of progression to pseudomyxoma. And that is why is our role is that if we call it TIS, it hardly progresses to pseudomyxoma and they will probably not follow up the patient much. And this is something very important that I think as pathologists we should know, that every Lemon when we diagnose, we have to ask ourselves that have we submitted the entire appendix? And if we have to put it in the comment that the entire appendix was submitted for histologic evaluation, because as we have seen that we can have a small focus of perforation, and which we will see only if we have examined the entire appendix. And the moment we have find the focus of perforation with mucin outside, the staging will change and it will be T4A. The second scenario, like as we have seen with Lemon which is ruptured and there is presence of acellular mucin. How do we report that? So that also we will call it that Lemon with rupture and extravasated mucin, that we must mention. And again, we write a note that there is lemon which is ruptured and there is acellular mucin, but without neoplastic epithelial cells. This also has prognostic significance, but still we will call it T4A per AJCC 8 edition. And these patients who had only acellular mucin, they have low risk. They still have a risk of progression to pseudomyxoma, but they have low risk. And this last comment we should always add. The third scenario that we have, again, we saw examples of this, when we have lemon that has ruptured, and along with the rupture, it has taken neoplastic epithelium with it. So if we see a lemon like this, so our report should go similarly. We talk about it and write a note that this lemon had ruptured, along with it there is mucin and neoplastic cells. And this will still be T4A, but we have to alert our colleagues that these lesions have high risk of progression to pseudomyxoma. And maybe this is the time, or even in the other situation, we pick up the phone and talk to them that we have found evidence of perforation and there is neoplastic epithelium. And these patients will actually be closely followed up so that they want to make sure that they do not have a peritoneal cavity evidence of pseudomyxoma, which is already developed, or they would follow up the patient closely. So what is the prognostic significance of extravasated mucin? There is this paper, which is a little old, but in this they have found that there is difference when there is acellular mucin versus cellular mucin in the periappendiceal area. And those patients who had cellular mucin, that means mucin with cells, they had worse prognosis as compared to patients who had only acellular mucin, that means without neoplastic epithelium outside. But however, from the surgeon's point of view, I have talked to many of them, and including Dr. Raouf, that they are going to follow up both this group of patients similarly. They're not going to take it lightly, and they will make sure that they have not left behind mucin inside the peritoneal cavity, and they are going to follow up these patients on a regular basis for any possible development of pseudomyxoma. So as we have seen that lemon prognosis stays dependent. If it is TIS, it's usually cured, so there is no problem. But if it is T4A, they both have high risk of progression to pseudomyxoma, and that is where our importance is. But what about resection margin? What if resection margins is positive? Then do we do an extended colectomy? So that's also, as a pathologist, our role. So we will be asked that question often. Oh, like, what about the margin? Was it positive? And what is its significance? Actually, the current evidence does not suggest that if the margin is positive, that they need to actually do an extensive surgery. And there was this paper recently in which they have studied 16 patients who had a positive resection margin for lemon. And in fact, none of them had developed recurrence or pseudomyxoma. So point is that probably positive margin is not a very important thing for lemon, because it's still on the luminal side, to keep that in mind, right? This positive margin is towards the lumen, it's not outside. And maybe these patients can be followed up, and we do not need to do an extensive right hemicolectomy for such patients with positive margin. This is something we should keep in mind as pathologists too. So let's move to a next case. Sorry,
Dr.
I think
Rifat?
I have taken a lot of time here.
Dr. Rifat, can you interrupt you for a relevant question here?
Oh yeah, sure.
Actually, you have shown us very nicely some of the practical scenarios what we can have with the LMN. Actually, we face a lot of problem with the consults, because when we get only 2 or 3 slides or blocks for review in our hospital, and we see LMN with mucin in the serosa, then we are not in a place to examine the whole specimen. And if there is presence of any cellular mucin pool or high-grade HMN. So in that case, in these cases, I found some of the reports recently which talks about SMAD4 IHC, which can loss can be indicative of HMN or a possibility of a mucinous adenocarcinoma. Do you have any experience on this?
Oh, that's an interesting question, and I think it's a very practical problem, right? If you get slides from outside, actually, we recently had a case, and they will only submit 2-3 cassettes or maybe 1 cassette, and you don't know what to do. So basically, that is our limitation, and we have to express that limitation when talking to the surgeon, that we have only 2-3 slides and we don't know how to exactly stage it, right? But talking about immunostain SMAD4, I think this is a very good suggestion. I do not personally have any experience, and in our institute here or even at UPenn, that is my previous institute, we have not used the SMAD4 in appendix. And I think we just rely on only two things, H&E and like submitting the entire appendix when possible. But I think this is something I would also like to read more about it. But thanks for that suggestion, Prasenjit.
Okay, thank you, sir. You can go ahead.
Okay, thank you. Let's go to the next case. So we are with the appendix still. And please remind me if I'm running late, Prasenjit.
Yeah.
So next case, again, we are with the appendix, of course. So this one is again a little different, but sorry for the blurred image at low power, it gets a little blurry. So we have a lemon which is involving the appendix, and this is a distended appendiceal lumen here with a lot of mucin inside the lumen of the appendix. Well, that's not a problem. But what I want to show you is that this is a too far. So this appendix also has something else going on at the same time. There is lemon and along with this other entity. So I'm sure you know what it is. So of course, this is nothing but a neuroendocrine tumor of the appendix. So you can sometimes have lemon with other pathologies. So that is also not to be forgotten. So just I wanted to keep you alert about that. The next thing that is very important is there are a lot of neoplastic mimics, especially the mucinous neoplasms, which are benign, but if we don't use proper criteria, so we can confuse them as lemon or other mucinous tumor. So I want to show you a couple of examples of that. And again, the history will be the same. The patient will come with acute appendicitis and there will not be any specific pathology or gross features. So I have one such case. I'm not going to trick you, but it's just a nice example about how we can be fooled about lemon. So this is an appendix. Again, this is a low power view, so which is little blurry, but I need to show you at the low power. So what we can see here is that, of course, I think it will get better little at higher power. Yeah. Well, this is a fine cross section of the appendix, but there is something happening here, right? We see that, okay, the lumen is dilated. That's fine. There is some mucin here, but that's not the case. But we can actually track the mucin. The mucin is getting through the wall of the appendix, right? And there is a little bit of dissection. And this is the best section I have. I don't have a better section, unfortunately. And at one point, so there is actually rupture, as you can see that this is not artifactual, right? There is a point of rupture. And see, this was the proximal margin, which was inked by our resident here. So this mucin has ruptured, and at the same time, there is some epithelial elements which has gone outside the appendix, okay? So now, when we see something like this, so what should be our diagnosis? I mean, this was a case which created a lot of trouble, and I will, and as we can see now here, like, I mean, there will always be a question about maybe like this is lemon, which is perforated and there is rupture with neoplastic epithelial cells. So that is the one thing that people will have in mind, first of all. But if you remember what we have just discussed, we still have our friend here, right? We have both our friends intact. We have a nice lamina propria all over, right? I mean, all across the lumen, the lamina propria is maintained. And the second friend is also here. All the crypts are here. The only thing that is happening in this appendix actually that it has perforated, all right? And we know that appendix always perforates, and that is the major clinical problem with acute appendicitis and perforation. But the moment we see mucin on the slide, why as pathologists we start thinking that this is a tumor, right? This definitely is not a tumor. But the problem here that I can understand that why we can think that it is a problem, that we can start thinking about lemon, right? Oh, because there is a mucinous epithelium and it is little hyperplastic. well, at this area, the lamina propria is lost, but we have to look at the disease as a whole, right? It's not at one focus that we make a diagnosis. But if we keep it in mind, so I think some of you must have got the diagnosis. So what is our diagnosis here, right? I'm telling you that this is a mimic, it's not lemon, and we still have lamina propria, we still have the crypts, and it is just only perforated. That's it. But what's our diagnosis? This is definitely not acute appendicitis. We don't have the neutrophils anywhere. There is no feature of acute appendicitis. I'm sure that some of you have made this diagnosis already, but if you look at the other section on the same slide, it will help us. So this is the other section on the same slide, where this is a little bad section, sorry about that. But we can see that there is something like the epithelium has actually pushed outside in this other section. And here again, our friends are here, both the lamina propria as well as the crypts. So this is actually a nice example of appendiceal diverticulosis. We can have, I mean, if this section was from the colon, the diagnosis would not have been a problem. But in appendix, we don't think about diverticulosis, right? But this is a nice example of appendiceal diverticular disease or appendiceal diverticulosis, which has ruptured, because diverticulosis in the appendix can rupture too, right? So, and in fact, this case was a problematic case. And when I first, and it was in my early days as an attending here, and there was a lot of debate in our group that whether to call it, and even among the GA pathologists, whether to call it a lemon or an appendiceal diverticular disease. I was in favor of calling it diverticulosis with perforation. So we had to send the case to Dr. Misrahi, who is the expert at Mass General, and he returned back and his report said that it is appendiceal diverticulosis with rupture and not a lemon. But something more interesting I want to show you about this case is this. Some of you might have seen it at low power. Look at this. If you look at higher magnification, this is very obvious. What is it actually? So this is nothing but decidualized endometriosis, right? These are the decidual cells. So this patient had a lot of things happening at the same time. So what might have happened is that in this focus, there was this area of decidualized endometriosis, and this area has actually created a possible defect. And through this defect, this diverticulosis or that appendiceal diverticulum has ruptured, and that has created a lot of diagnostic confusion about calling it lemon or what. So I'm trying to show you this example because sometimes appendiceal diverticulosis can mimic lemon, and as pathologists, we need to keep that in mind as well. Yeah, that was the diagnosis. I want to show you a couple of more examples of appendiceal diverticulosis, which are very interesting. And if you keep in mind, so, and if you are at least aware of it, that appendix can have diverticulosis, we are not going to make that mistake and call it as lemon. So, and not all slides will present as diverticulosis, but like we have to be aware of it. For example, this is a nice example of appendiceal diverticulum, which is nicely going through the wall of the appendix and seeing here. But the problem is when we see only this area, we will start thinking that maybe like this is lemon. See that this epithelium is attenuated. That can happen. The another problem with appendiceal diverticulosis is hyperplasia of the epithelium. So because if we look at this area, we will start thinking that, oh, this is probably a lemon. And here our friend is kind of gone, so there is no lamina propria. But in this particular example, we are not going to make that mistake because we have seen this nice diverticulum which is going all the way through. And let me show you another example. Oh, sorry. Because it can come in various flavors, the appendiceal diverticular disease. So here again, in the same slide, and this is from the same patient actually, how it can present in different ways. So this is a nice diverticulum. The diagnosis is not a problem. And as I said, I mean, when we look at this, we have a problem because we will start thinking that, oh, this is probably diverticulosis. But sometimes in our sections, the diverticulosis looks like this. So we have double lumen, we have triple lumen like here. So then also we are confused sometimes that, hey, like maybe this is actually lemon which has gone wrong. But if we take more sections, actually, we will probably be able to see this nice continuation, because in this same appendix, we have on the same slide, there is this nice diverticulum, and which is just because of the sectioning, we are looking at like this. And it is very similar to what we see in colon, for example. But to make matters more difficult for pathologists, I want to show you this another example. So here, so this is probably, oh, there is a lot of mucin, right? Which is distending the appendix. And if you look at the epithelium, well, the epithelium doesn't look good. So this is, our friend is not there. There is no lamina propria, and we have mucinous lining. So this looks like a lamen. Well, but what is this? What about here? So it's again, it's like a double lumen, right? At low power. So this is a double lumen. And if you look at this small area and go to a higher power, we can still see that this has the same morphology like the other area. It has a mucinous epithelium and there is no lamina propria. So basically sometimes, which is rare, of course, we can have lamen involving appendiceal diverticulosis as well. So, but still, as an important mimic, we need to remember that appendiceal diverticulosis is a very important mimic of lamen. And this is a nice picture which shows the different histologic images that you can have of appendiceal diverticulosis. But like, we just have to make it 2 and 2 to make the diagnosis of lamen. And in fact, this is another section from the same case in which we had rupture with decidualization. But on this slide, we can nicely see actually the diverticulum here. There are 2 good papers which you can refer to. There is one paper in histopathology, which is from a group from UK. They have talked about complicated appendiceal diverticulosis, how it mimics lamen. And here is a more recent paper in modern pathology by Dr. Rhonda Yantis and her group. And they have also explained, I mean, the differences between diverticulosis and lamen. So you can read this and this will explain. And basically, as we have seen, that if you want to call it lamen on our right side, you see loss of lamina propria, filiform architecture, and hypermucinosis. And on the left side, when we think of diverticulosis, think of the retained lamina propria. But sometimes you can actually say epithelial hyperplasia, which can be confused as hypermucinosis. So we should not be distracted by that. And maintain crypt architecture, that is very important. As you can see here, let me go to the previous picture. The crypt architecture is still maintained. We can see the crypts here. That is not what we see in lamen. So we just forget that. It's very simple. So here there is no crypt architecture in the lamen. We have seen a lot of lamen now. So let me show you the next case. I think I showed that already, lamen involving the appendiceal diverticulum. The another mimic of lamen is retention cyst. So retention cysts are often, those are the ones which some people want to call it as mucocele, but I would suggest that we should stay away from calling something as mucocele. That's not a correct histologic diagnosis. We can call it a retention cyst, which can resemble lamen. I don't have a slide of that, but I have these images from a friend of mine. So this is again a dilated cyst where we see that it looks like lamen again. Well, this is an attenuated epithelium, but the good thing is that why we start thinking of lamen is that in many situations, in reactive conditions, the epithelium can become hypermucinous and it can resemble a neoplastic epithelium. But if you remember our friends again, we still have the lamina propria here. It is attenuated, but it is still there. And if you remember here, the first case that I showed, that the dilated appendix that I showed. So if you go back to that slide and think of it, that, hey, this is the same thing. Like, it's just a dilated appendix, but the lamina propria is retained. So this is what we will see in a retention cyst. Again, this is another example. The lamina propria is retained, but when we look at the mucinous epithelium, we get confused and we start thinking that this is lamen, but it's not. It has a lamina propria, it has the crypt still. So this should not be called a lamen, but it's a retention cyst because it has diagnostic implication for the patient, as we have seen. And another third mimic, which I have not included here, is I think I mentioned that when you have appendiceal endometriosis with intestinal metaplasia, that can sometimes mimic lamen, and we need to be aware of that entity as well. I don't have an example of it, so I'm sorry I'm unable to show it today. Let's go to the next case. We are switching gear quickly. There is no more lamen. but again, the history is the same. It is acute appendicitis. But look at this. This is something different, and I'm sure that this does not look like lemon now, right? Because I mean, it's not normal, of course. So we have the obliterated lumen here on this other section. So probably this is fibrous obliteration here, but this is here we can see that this looks something different, right? But it's not lemon, you know, like we have lamina propria, but it's like hyperplastic epithelium, that is obvious. And if you would have seen this example in a colon, the diagnosis would have been very straightforward. So it is a sessile serrated lesion. So that's the new terminology, right? We don't call it sessile serrated polyp according to the WHO anymore. So the new name for sessile serrated polyps or adenoma is sessile serrated lesion. So this is again the classical sessile serrated lesion where we have hyperplastic epithelium with serration. The serration is going all the way to the base with dilated crepes. So this is very classical of sessile serrated lesion involving appendix and without dysplasia. Let's talk about that. So sessile serrated lesions of the appendix or serrated lesions of the appendix are classified like this. Similar to colon, we can have hyperplastic polyps or sessile serrated lesions, which can be without dysplasia or with dysplasia. But we do not usually have traditional serrated adenomas involving appendix. That's not in the WHO classification. Someone might have seen, but I'm not aware of it. And these lesions appear to be distinct from colon, and from molecular standpoint, the serrated lesions in the appendix are less frequently BRAF mutated as compared to the colon. And in fact, KRAS mutation is more common in serrated lesions in the appendix. And the importance from the clinical point of view is that serrated lesions, likely they do not cause pseudomyxoma peritoniae. I don't have the exact data with me, but that's why we should not call them lemons. So the lemons are the ones which can give rise to pseudomyxoma, and serrated lesions are more often they are confined and they do not rupture. But the problem is that serrated lesions can also progress to invasive adenocarcinoma of the appendix. So I want to show an example of that very nice case. So in which serrated lesions sometimes can be problematic. So this is a slide that was shared, that was signed out by my colleague at Penn, Dr. Zhaohai Yang, and he has been very kind to let me share this case with you today. But thanks to Zhaohai. Look at this, for example, here. Let us not look at the lumen now, for example. The lumen looks different, but if you look at the periphery, so it looks like a serrated lesion that we saw before, or like a sessile serrated polyp in the colon. So if you look at here, so this looks like a sessile serrated lesion involving the appendix. That's not a problem. But already we see that there is something wrong that is happening in this case, that why we have so much of dysplastic epithelium inside the lumen. But if it is inside the lumen, we cannot say anything, right? So we have to definitely examine more sections, and let us look at more sections from this same specimen of appendix, and it will show us a different picture. So at many areas, it looks still like the sessile serrated lesion, but we can see here, for example, that this area is becoming worse and worse. We have high-grade dysplasia here, but in fact, we can see the abrupt transition from this area of sessile serrated lesion, which is progressing into high-grade dysplasia. And in other areas, we can actually see a nice example of invasion here. So we can already see signs of invasion developing in this polyp. And let me show you another section from the same specimen, how this seemingly innocuous sessile serrated lesion in the appendix can actually give rise to an adenocarcinoma. Wait a second on this case. Yeah. So here, this is from the same specimen, and actually we see that there are clear-cut areas of invasion here. So this is a nice example and of sessile serrated lesion, which has developed into an invasive adenocarcinoma. And once again, I would like to thank my colleague, Dr. Zhaohai Yang, for sharing this slide. Let's go to the next case. So staying as polyps in the appendix. So let's talk about look at the low power. So not everything in appendix is about lemon. So if you look at this here, for example, so this is not a hyperplastic polyp, but it definitely is a polyp here, right? And if you look at higher power, so this is definitely like a villus adenoma. This is not a serrated lesion anymore. It's like a villus adenoma, like what we see in the colon counterpart. And maybe in some areas there is high-grade dysplasia already. So in fact, this was a very interesting case. For example, like, I mean, when I started seeing the case, and the first few slides showed this. But when I looked at more, and I have another section on the same slide, we will see that this was an aggressive lesion. So there is already areas of invasion here. So you might say that, oh, why this is not prolapse? So this is not prolapse, this is true invasion, and which is happening here. And I had the opportunity to look at more slides, so which I unfortunately don't have now. So this is an example of actually villus adenoma involving the appendix. And in this particular patient, the patient already developed a focus of adenocarcinoma as well. So you can rarely have villus adenoma involving the appendix as well. That's what I wanted to show you. The next case, staying with neoplastic lesions in the appendix. So this is again, the histology of the grossly, there was no specific finding. The patient presented as acute appendicitis. But here's the morphology here. So at low power, we can see that this is totally different from what we have seen so far. There are a lot of mucin, which is dissecting through the wall of the appendix, and not exactly true, but it is still confined. But within the mucin pools, we can see this floating kind of mucinous epithelium. And if we see this same example in the colon or in the breast, the diagnosis is not difficult, right? So this is a classic example of mucinous adenocarcinoma involving the appendix. And I have another slide from the same patient, which looks little different. So I want to show you that. So here again, we can see this mucinous mucin pools with this neoplastic epithelium, which is floating around. And this here is actually dissecting through the wall, like we can see here, right? And at some places here, not exactly through it. But what I want to bring your attention is a focus here as well. So in this same lesion at low power, so we also have a focus like this. So which, if it was alone, suppose this other area was not there, we would have called it a lemon. So this is an example of association with lemon with associated mucinous adenocarcinoma of the appendix. So now I'm not sure that what is the exact association between lemon and mucinous adenocarcinoma, and I don't have much of data that, or I have that if the lemon actually, it's not yet proven that if lemon can transform into a mucinous adenocarcinoma, and if there is a continuation like tubular adenoma in the, like how adenomas in the colon progress to carcinoma in the colon. So, but still you can have lemon with associated with mucinous adenocarcinoma. So that brings to us the question about the adenocarcinomas involving appendix, and WHO has classified them as like this: non-mucinous, mucinous. It can be signet ring cell, which has bad prognosis, and there can be an undifferentiated carcinoma involving the appendix as well. So at this point, there is something which is important, that because sometimes we may confuse a lemon from and a mucinous adenocarcinoma, and how do we differentiate that? So what we do is that the pattern of invasion is very important. For lemon, it is usually a broad pushing type of front that we will see. And if we talk about mucinous adenocarcinoma, it is usually an expansile pool of mucin with neoplastic epithelial cells that are floating around. So that's the best way to differentiate whether this is a lemon and a mucinous adenocarcinoma, because in practice, many a times we can see that pools of mucin will be dissecting, and it's very hard sometimes to differentiate between a lemon and mucinous carcinoma. Let's go to the next case. And I just want to show you an immunostain characteristic of this mucinous adenocarcinoma, which is very obvious actually, that these mucinous adenocarcinomas of the appendix, they will obviously be CK20 positive. It's basically not needed to make a diagnosis, but still, like They are usually CK7 negatives, 20 positive, and of course CDX2 will be positive as well. I want to show you the next case. So this is again the same story, acute appendicitis, and we have no specific gross morphology, but there are multiple sections. And for the trainees, I just want to show you that how it is important to look at all the sections. So these two sections are, again, nothing much is happening here. But if we look at this section, the last one, there is something wrong here. So let's go to higher power. At low power, we can already see that there are some glands like which are infiltrating the wall of the appendix. And at high power, if we look them closely, we see that they look like they have a lot of goblet cells in it. There are a lot of goblet cells and they are taking different shapes and they're infiltrating the wall of the appendix, right? And some places, maybe we will think that, oh, is it signet ring cell? But if we see that they are actually are in tight clusters here, not like a signet ring cell. So if we see that, this is so different from what we have seen so far. It's not a mucinous adenocarcinoma, or it's not a lemon, but this has actually gone outside too. So this is not a very good disease, right? And here you can see actually this has gone outside the walls of the appendix and the same morphology. So if we have these, so what's your diagnosis? And I'm sure you know the diagnosis, which is not very difficult. So this is goblet cell adenocarcinoma of the appendix. Prior to 2019, we would have called it differently. So maybe we would have called it goblet cell carcinoid with the same morphology, right? That was the histology. Like with that histology, the terminology that was existing was goblet cell carcinoid, and we would have called it goblet cell carcinoid. But now this would be diagnosed as goblet cell adenocarcinoma of the appendix, and we can grade it as grade 1, and we will talk about the grade in a minute. And there was the other entity prior to the new WHO that it was called adenocarcinoma X goblet cell carcinoid, which many of you have diagnosed. But this is a very confusing terminology. Goblet cell carcinoid itself is really confusing because if you know that carcinoid makes it look like a neuroendocrine tumor, just because it was expressing synaptophysin, so it used to be called as carcinoid tumor, but it is not a carcinoid tumor, right? And pathologists start using the neuroendocrine staging system, and the oncologists think that it is an endocrine tumor, but like, I mean, it's really confusing. And the other terminology that is adenocarcinoma X goblet cell carcinoid was also confusing because it's not that adenocarcinoma has developed on top of a goblet cell, that there was no proof of that. So they are actually considered distinct. And that's why this new terminology in the WHO classification is to call it, to get rid of goblet cell carcinoid and this other terminology, and call it goblet cell adenocarcinoma as a unifying terminology for both these group of tumors and grade them. Like this would definitely be low grade and this is a high grade. That this is the WHO grading now, that we should call it grade 1, 2, and 3, and based on low grade and high grade morphology. It is somewhat similar to, I think, that breast carcinoma grading that we do, that Bloom Richardson grading based on the low grade pattern and high grade pattern, and based on the percentage, we call it grade 1, 2, and 3. And the other terminologies should not be used at all. Now, how do you define it? Basically, goblet cell adenocarcinoma is the appendiceal tumor with goblet-like mucinous cells and variable amount of endocrine cells. And gross, there is nothing, no gross specific of that. And these lesions should be staged at appendiceal adenocarcinoma, because that would be the next question, right? What staging system should we use? Should we use for neuroendocrine? No. WHO recommends that goblet cell adenocarcinoma should be staged using the same staging as appendiceal adenocarcinoma. And the prognosis of the tumor depends on stage and tumor grade. And the important thing is that they can also produce pseudomyxoma peritoneae. And I want to show an immunostain for goblet cell adenocarcinoma. That I have it, I guess. This is a synaptophysin. Synaptophysin is variable. Sometimes it stains only a few cells, like here. So these cells are positive for synaptophysin, like we can see here. yeah, some of these cells, like these guys, which are positive for synaptophysin. But sometimes actually synaptophysin can be very diffuse also. I had one case in which the histology was that a goblet cell carcinoid. That was not a problem, but there was diffuse staining for synaptophysin. Let me show you that. Like here, for example. So these are the cells like which are very strongly staining for synaptophysin almost everywhere. So you can have variable staining with synaptophysin. And with that, this is CK20 in one of the goblet cell carcinoids that we had. So as we have seen with mucinous adenocarcinoma that they are nicely CK20 positive, and this is the normal epithelium of the appendix, which is CK20 positive. So these goblet cell carcinoids are also actually, they express CK20. So kind of you can say that they are more similar to the adenocarcinomas than something else. So this is nice CK20 positivity. But what I want to emphasize, one thing is that we usually don't need an immunostain to make a diagnosis of goblet cell adenocarcinoma. It's usually a morphologic diagnosis, and most of them are actually low grade. They will be grade 1. And what is important for pathologists at this point is that it is on us to now educate the oncologists and the surgeons that this is the new terminology for goblet cell carcinoid, because they may not be aware that goblet cell adenocarcinoma is the same entity which since till 2 years back it was called carcinoid. So I mean, it's for us to pick up the phone when we make this diagnosis and have a chat with our colleagues on the other side that, hey, I called one case as goblet cell adenocarcinoma, but this is the same entity. I just wanted to let you know. And they would be aware, most of them too. So this is on us now to do that job till this entity is well established. So that's all about the malignant lesions, but sometimes the appendix shows you some subtle things which we might miss and which are not so obvious. I have one example of that. Let me show you the next case. Here it is. So this is again a slam dunk, like same old appendix with multiple sections of it. So this is a fibrous obliteration, and again this is a dilated appendiceal lumen. So I want to show this again and again because dilated lumen of the appendix is very common. Whenever there is a large ficolid, the lumen will be dilated, but that does not mean that we should think about making a diagnosis of lemon the moment we see that the epithelium is attenuated. But I'm not going to show you that here. I want to show you something that is happening here. And here again, I want to thank my friend, Dr. Arman Karajian, for sharing this slide with me. And he had that case. He was the lucky one, I would say. And there is something happening here, which we would have missed if we were not very careful. I think Dr. Karajian is a friend who has very eagle eyes, and he is one of the very good morphologists that I have come across. He doesn't miss things. So here it is. So there is something happening here. Let me show you at, sorry, 20x. Okay, so there is something here. And if you go to a higher magnification, we can see that these have a typical morphology. They don't look like epithelial cells, and what they are doing, you know, towards the luminal side of the appendix. And many of you, I'm sure they maybe like, you know, they look like some, these cells have a lot of cytoplasm, right? And the nucleus is somewhat vesicular, some have prominent nucleoli, and just think of it at other locations. And maybe some people will think that, oh, this is decidua, maybe decidual cells. But I'm sure some of you have already made the diagnosis that these are all ganglion cells. And in this background, you have some neural elements also. So this is actually a nice example of ganglion neuroma. So thanks to Dr. Karajian and his subtle and sharp eyes. So he called it a ganglion neuroma, and which is very rare in the appendix, but you can have it. So, I mean, this shows that how important it is to look at all the slides, all the sections on your slide of the appendix, so that you can pick up some unusual entities sometimes. The last case I have, sorry. So sometimes you can have some weirdos in the appendix. So we should keep an eye on those as well. Let me show you that. So this is again, it was my case. It was sent as acute appendicitis. So, and when I looked at it, well, it looked too blue to me. I mean, definitely there is no appendiceal epithelial proliferation here, and we see the lymphoid aggregates. But what about here? It looks really too blue to be true, right? And there were two sections here, both had the same features. Then definitely like this cannot be something too normal, right? And at low power, the one thing we will think that, oh, this look like probably, let us see what is going on. And they don't look epithelial. But if you go to higher power, you can see that definitely these are not epithelial cells. Or maybe one thought that came to my mind is that maybe there are some eosinophils here, some of them. And at higher power, we can see these cells better. They are very monomorphic. Some of them have a vesicular chromatin, and some of them are angulated. I can see many cells which are angulated and grooved nuclei. And there are a lot of eosinophils in between also, I saw. Well, is it a non-Hodgkin lymphoma of some sort? That was the first thing that anybody would think, right? And so I'm sure some of you might have got the diagnosis already, those who have more interest in hematopathology. So, and this patient actually, when I looked up the chart, this patient was recently diagnosed with acute myeloid leukemia. And so this is actually a classic example of myeloid sarcoma involving the appendix. And we did the immunostains. I don't have the slide with me. Myeloperoxidase was nicely positive. So we were able to make the diagnosis of myeloid sarcoma, which is very rare to involve the appendix. But I just wanted to show this example so that to make sure that we don't miss some weird diagnosis sometimes involving the appendix. And as one of the cases in our series, there can be sometimes rare metastatic lesions going to the appendix as well. So we have to keep an eye on those. So just that, those are all the cases that I had shown. I'm sorry, I think I have probably overshoot the time. Sorry about that. But what I want to emphasize, especially for the trainee, is that appendiceal pathologies are not always so vestigial, as the name of the organ probably says that vermiform appendix, it's a vestigial organ. But it, on the other hand, actually it can present as a Pandora's box with a lot of different pathologies. You can call it a potpourri of neoplastic and non-neoplastic entities in the appendix, and there are a lot of mimickers as well, so which can involve the appendix. And of all these different entities, one group of lesions are very important, are those mucinous tumors, which are either low-grade appendiceal mucinous neoplasms or high-grade or adenocarcinomas. And importantly, when we diagnose Lemon, definitely, first of all, we should diagnose it properly to know the criteria, of course. But at the same time, we should make sure that confirm that whether it is localized or whether it has ruptured. And if it has ruptured, let us make sure that if there is acellular mucin or there is mucin with neoplastic cells. And to make that happen, we have to make sure that we have submitted the entire appendix. And if we don't do that, that distinction is not possible. And as Dr. Prasenjit Das has mentioned, that sometimes you don't have that luxury, because if you are at AIMS and you have got 2 slides, so what are you going to do? You cannot reach out to the host pathologist who got the, or host institute who got the original specimen, or maybe the specimen is coming like after 2 years and you have only 2 slides or 1 slide. Now, how do you know like what is happening? And then that is, I mean, that's a problem which we cannot solve, but at least, I mean, prospectively, I mean, we can think about it. And if you're aware of it, that the moment we see something as mucocele, like what many people used to call mucocele, let us submit the entire appendix. And after that only, like, make this distinction. And if we cannot make that distinction in our setup, so that we can send it to a higher center and the experts can look at it and make the diagnosis. Another appendiceal mucinous neoplasm that we should not forget is that serrated polyps. As we have seen that they do exist. You can have sessile serrated lesions, and as Dr. Jauhai Young's case that I showed, that it can actually give rise to an adenocarcinoma. This is rare, but it can happen. And you can also have villous adenomas in the appendix, similar to colonic villous adenomas, and they can also give rise to adenocarcinomas. And lastly, but goblet cell adenocarcinoma is the new terminology which I wanted to emphasize today, and it replaces the erstwhile goblet cell carcinoid. So we should not call anything as goblet cell carcinoid anymore. And if you go to the WHO book, so we will be able to read more about this entity. And last but not the least, so what I want to emphasize, especially to the trainees, is that gross the appendix well and submit entirely. I cannot overemphasize it much. We need to submit the appendix entirely the moment we think that it is a mucinous tumor. And always in the proximal margin as a routine, because we don't know like which appendix will have a lesion or tumor. So basically that all appendix, if we ink the proximal margin and submit it as one section, that is important so that we can always have that section if it is a tumor in one of the slides. Otherwise, we will not be able to comment on the margin. So as pathologists, of course, it is easy to recognize the obvious pathology. So let us do that. And always keep an eye for the mimickers, because there are a lot of mimics, as we have seen, that which will look like tumor, but they are not tumors. Basically, you can say that sheep in wolf's clots or whatever. And sometimes we should, as pathologists, look for the subtle ones. And once in a while, we will have the weirdos like a myeloid sarcoma involving the appendix. So we should keep an eye on that also. And last but not the least, of course, enjoy your appendix. And that's all from me today. And thank you so much. And if anyone has questions, I'm happy to take them and I will try my best.
Yeah, thank you, Dr. Rifat, for completing so many cases within the time. Now we have compiled some of the questions. Myself with Dr. Rajni Jadhav, my colleague, will take up the questions. So can we start the questions, if you are okay?
Yeah, sure.
Okay, the first question, it was asked by Dr. Bala Murugan. How often do you see fibrous obliteration of the appendix, and can it be symptomatic?
Oh, that's a good question. Actually, it's a very common finding. I think every other time you can find fibrous obliteration, and it doesn't have any specific finding. And many of the cases that you get as acute appendicitis, you can find fibrous obliteration. It may be standalone or it may be associated with acute appendicitis. That might be your experience as well, Prasenjit. So, you just mentioned it, that there is, that's all. What do you say, Prasenjit?
Yeah, it's true. It's true. It can be age related also most of the times. So, but it can be associated with other pathologies.
Right.
Okay. So we can take up the next question. It was asked by Dr. Shananda, how to differentiate between the LAMN and mucocele.
How do you differentiate between, sorry?
LAMN and mucocele of appendix.
Right. So, as we have discussed it, that let us forget mucocele for the time being. Let's not think about mucocele at all. So mucocele is a very broad terminology. Whenever a hollow organ, think about it. Whenever there is a hollow organ which is having mucin inside, is called a mucocele. Think about the ranula inside the mouth. That's called a mucocele, right? What is it? It's the same thing. It's a cyst with mucin inside. That's called a mucocele. Because appendix is small, when there is mucin inside, we used to call it mucocele. Let's forget about that. But there is how to basically you should think about how to differentiate lamen from retention cyst maybe. And as we have talked about the different criteria, always look for the normal appendiceal lining. So, and then the luminal area. So as I said again and again, that our friends are the lamina propria, right? Look for lamina propria inside the underneath the epithelium, and also look for the crypts. If you see the crypts and the lamina propria, then you will be good. But there will be always problems in practical point. Like if you see the sections, like you think that, oh, this is probably like, it is distended with mucin and it looks like a lamen. What do you do? But you're not sure. And again, the first thing you do is submit the entire appendix. Don't think about it. Don't take deeper sections or whatever. Submit the entire appendix. And then once all the slides come, relook at it. That way you can save so much of time, because most of your answers will be there in the next few slides. And if the next few slides you see a lamen, then you don't have to worry. And if you don't see a lemon in all the appendix and you are worrying about only one area, then probably it is not. Then you can show around with your colleagues, or maybe if you still debate, you can show to an expert. But I think if you think about the lamina propria and your crypts, and most of the time, I think you would be able to differentiate between so-called mucocele and the lamen. But I would say that I would like to emphasize that we definitely should forget that there is none of the books you will find in pathology that there is something called mucocele, right?
Sir, the next question is, it is a very interesting question by Dr. Fonseca. Role of frozen sectioning in appendicular mucinous neoplasm. Do you have any experience on that?
Yeah, that's very interesting. People usually don't do that because there are a few. This is a very good question, because most of the time, the majority of the time, the appendiceal mucinous lesions are not picked up on radiology. Most of the time, if you are lucky that that radiology had a distended like mucin, and then you think about it, then you can do a frozen section. What do you do about the frozen section? Maybe the frozen section is of the base of the appendix. You do not do frozen section of like the appendix to make a diagnosis of lamen, right? I personally have not dealt with any frozen section for lamen or mucinous lesions in the appendix, but Prasenjit might have. There is one situation in which you can have frozen section, but still that is not much. What I will tell you is that if the patient has developed pseudomyxoma, sometimes when the surgeon is like, planning a surgery, they might do it because pseudomyxoma is also graded. We have not gone to that today, that pseudomyxomas are also graded as grade 1, grade 2, grade 3 WHO. And based on that grading, the treatment is also different and the patients behave differently on pseudomyxoma. So sometimes those specimens can be sent, but again, they are very rare. But I have talked to a surgeon also recently that, do you do that? So they say that no, they don't do that. Usually they will send you needle biopsies of different areas, to look for proper grading of pseudomyxoma in patients. But frozen section, no. Do you have any experience, Prasenjit?
No. We also don't receive frozen sections for this purpose, actually.
No.
Yeah. So, Dr. Rajni, can you take up the next couple of questions?
Yeah, sir. So there is a question from one of the attendee that in the case with LAMN and neuroendocrine tumor, can we call it mixed neuroendocrine, non-neuroendocrine neoplasm? Or should we keep it as two different entities?
That's a good question, actually. Thanks for asking that, because that is an entity, right? In the neuroendocrine neoplasia classification, MIN-N, right? Mixed neuroendocrine, non-neuroendocrine neoplasm. And if you have one component more than 30%, then you can call it, right? But in this case, you see that actually think of that case per se, like MIN-N is when you are classifying neuroendocrine tumor, then we are thinking of that, right? Usually you will have an epithelial component and which is intermingled with an neuroendocrine component, right? But appendix is a bit different. For example, we are looking at two very common entities in the appendix. Many of the appendices will have neuroendocrine tumor, like as an incidental finding, as we have seen, or we called it carcinoid before, right? And then that you can have a lamen as an associated finding, but I don't have a real answer for that. But I would stay away, especially in this example, to call it a MIN-N, or rather I will call it that they are both associations. If others have other thoughts that you can share, but that's what I think.
Yeah, sir, in this case, they were distinct and separate. So I think separate is better.
Right.
It was not one tumor also.
Not one tumor.
There is another question that do you sign out as recurrent appendicitis? So, sir, mostly in our center also interval appendicectomy is done. So there are no polymorphs. So the heal, the fibrous appendicitis or the recurrent appendicitis, how do you use these terminologies?
I think that's a very vexing problem. What I have dealt with whenever it is I probably called it findings consistent with interval appendectomy, C note. So in the note, I will talk about this, like what are the findings, and then say that only if I'm sure, because see, like, I mean, if I don't know, it can have a lot of mimics, right? I mean, if suppose I see fibrosis, lymphoid aggregate, and it can be anything, right? Only if I know that the patient's history is like this, because interval appendectomy, you can make that diagnosis only if you know the history of the patient, right? And if you know the history, then you can write it in the comment that, I mean, the patient's history is noted so and so, and based on these findings, most consistent with interval appendectomy. But suppose a patient has Crohn's disease, okay, along with, and the patient also had interval appendectomy. That's sometimes in a practical case, it is difficult to differentiate. And there are a lot of papers which are addressing that. And in fact, the paper by Dr. Misrahi that I mentioned, which talked about actinomyces in the appendix. And he has extensively discussed the different findings that you see in interval appendectomy and what is the difference. So maybe that can help you. But in a single case, which is coming to you on a day-to-day basis, so maybe you can deal with as a case-to-case basis and put it more in the comment and not on the top line, because that's a wrong top line diagnosis to me, you know, because I mean, you can just put it more on the comments.
And I think Dr. Rifat and Dr. Rajni, both of you will agree to me. These two terms actually are used interchangeably, chronic appendicitis and recurrent appendicitis. And the classical teaching says if there is a intermittent obstruction, that will lead to recurrent appendicitis. And if there is a permanent obstruction, that will lead to chronic appendicitis. But from a practical point of view, from a pathologist point of view, using these terms are very confusing. We actually, whenever see chronic features of chronicity, we call it chronic recurrent appendicitis. We don't use the term chronic appendicitis. So you can say your experience.
Right. Yeah, you're right. Exactly. That chronic appendicitis is hard to use as a terminology on a report, right? I don't think there is much evidence, and we don't have much like to talk about that. I agree with you.
And so one question about LAMN, that if we are not seeing perforation or mucin going through and through, but in then one section there is mucin on the outer surface of the appendix. However, there is another biopsy from the parietal wall which has been sent separately, and that shows reaction, sheets of foamy histiocytes. So that means that that mucin has dissected. So probably should it be staged as PT4?
So I think that's a very nice question, and it's a tricky one. But what my approach would be is to have evidence in my hand. I'm not going to assume anything, right? If there is a biopsy from the parietal wall which only shows foamy macrophages, it can be due to 100 regions. It is not on me just because, I mean, there is a lamen on the other specimen. I will think based on the foreign body reaction and foamy histiocytes, I am making an assumption. I will never do that, because I think unless I see some evidence on the biopsy of the parietal wall, I will not make that assumption. And I'm not going to write it on the comment. Maybe you can talk to the surgeon that, hey, like, because they know better. Sometimes I would always think that we have to put a lot of emphasis as pathologists on what is the patient's presentation, right? And what is happening. We cannot work in isolation and just look at the slide and make a diagnosis, right? Our job is to make our diagnosis impact the patient's treatment and prognosis, right? Then we need to know what's the radiology, right? What is happening? And pick up the phone, that what did they find in the surgery? Was there mucin in the peritoneal cavity, right? If there is only mucin outside the appendiceal wall, maybe that there was little mucin inside just that appendiceal fossa. That is not very clinically significant for the patient, right? So even then it will help us to know the prognosis and make it easier for us. I think probably that's the best approach, and let us not assume like, you know, that this might have ruptured. I will not do that.
Thank you, sir.
We have a couple of more questions. Dr. Rupesh asked, retention cyst is a pathological entity and mucosil is a clinical term. Is it like that?
I think I have thought about it myself, but I have a different answer to that. So why why as pathologists, we also always think that clinical and pathologic is different, you know? So mucosal is a clinical entity. So I agree that is pathology also not part of clinical medicine? So pathology is also part of clinical medicine, right? So you can say that mucosal is a terminology which is used more often when a physician sees the patient, right? When it is in the patient, right? Probably that is when more often mucosal is used, right? But retention cyst probably not much used in clinical day-to-day practice, right? Like, I mean, wherever it is, whether it is in the oral cavity or other places, maybe it is often like the often called the mucocil, right? Even in the oral cavity, it is more probably by the ENT surgeon or ENT specialist called the mucocil, not a retention cyst. It can happen, but I will not make that distinction between clinical and pathologic thing. Like, I mean, but as pathologists, we should definitely stay away from calling mucocil because there is no histologic definition of mucocil. If you look at any histology book, any general pathology book, there is not in the classical teaching, there is nothing called mucocil, right? So, I mean, it is something like a sebaceous cyst, for example. Sometimes we call sebaceous cyst, right? I mean, if you see an epidermal inclusion cyst, many of us want to call it a sebaceous cyst, but is there any histologic description for sebaceous cyst? No. This is the same analogy you can use. For us, it is an epidermal inclusion cyst, period. But then always that question will come from students that is it a sebaceous cyst? But there is no terminological sebaceous cyst for the histologist, right? It is something like that. I think that's my take on it.
Yeah. Dr. Rajni, do you have more questions?
So there is another question. How to report appendices removed with other surgeries, considering it is otherwise normal? So,
yeah, same way. If it is otherwise normal, that will come often. Like the most common finding that you will find in otherwise normal appendix is probably fibrous obliteration. That you will see that just comment on fibrous obliteration of the tip. Then you said you can say that a second line is that the rest of the appendix has no significant pathologic abnormality. It's probably not a good practice to call it normal appendix because something might be we can avoid it. Or otherwise you can say that vermiform appendix, histologically unremarkable, no acute inflammation seen. And if this appendix was removed as a separate specimen, right? Like suppose they did an appendectomy and also some other specimen which had tumor, then I would say that vermiform appendix with no significant pathologic changes, negative for tumor. That line is important, right? If this is a separate specimen, but if it is part of the same specimen, just mention that whatever is the finding, or if there is no finding, no significant abnormality.
Right. And I think there is a thoughtful long question. Why behavior in nomenclature is not denoted in appendicular mucinous neoplasm, though there is chance of pseudomyxoma peritonei? We call them neoplasm only. Why like this? Your thought on this by Dr. Navonita.
I actually probably I did not understand it exactly well. What is it saying, Prosenjit? Can you tell me?
She is asking actually with appendicular mucinous neoplasm, there is always a chance of pseudomyxoma peritonei.
Right.
So she is saying why we are calling it a neoplasm, not a carcinoma. I think so. She wants to ask.
Right. That is, I think that's a very good question. I think that is still an evolving paradigm, right? The problem is like, I mean, it's a vaccine thing. Like, I mean, the more and more we, I mean, just to give my thoughts on it, the more and more we understand, the more, because some of the terminologies in pathology are based on morphology, right? What we see, low grade and high grade. It's not always true, right? For example, pseudomyxoma peritonei, we will probably, when we have a specimen, we will call it mucin with low grade epithelium, right? And pseudomyxoma peritonei also has grading now, grade 1, grade 2, grade 3, right? Grade 1 has very benign looking epithelium with mucin. It looks good, not very abnormal, but think of the patient's point of view. Sometimes I think pathology and pathologic terminologies are not exactly reflective of what is happening to the patient. if it is low-grade pseudomyxoma peritoneae, the patient already has a very aggressive disease. You know, the patient has an aggressive disease, and even if it is low-grade, patient will need cytoreductive surgery and HIPEC, which is a very aggressive treatment, and prognosis is probably not good. But as pathologists, we are calling it low-grade. But, and coming to your point, that does it reflect the actual like clinical situation that is happening with the patient at that time? Probably not. The same thing with Lemon too, I think, you know, like that's a very good question. I think always that medicine is evolving, pathology is also evolving. The more now we are having this question, maybe after 10 years, we will not have this question, right? Because we will have more understanding of molecular findings in Lemon, and then maybe there will be a more unifying concept about Lemon will be called low-grade mucinous carcinomas. Because when we talk today on like March 27, 2021, we talk on what evidence we have till yesterday, or what evidence has been published till last month. We cannot talk about like the evidence that is not in our hand. That is how I think the medicine has progressed, right? And that is how it is going to go. And the same thing with goblet cell carcinoma. Think about it. Till the WHO classification, everybody used to call it goblet cell carcinoma, right? Everybody. And no questions asked, right? Like in best of the best centers, the diagnosis is goblet cell carcinoma. But are the patients behaving as goblet cell carcinoma? How many of us have thought about that? Have we followed up those patients? We have not, right? We make a diagnosis of goblet cell carcinoma and go move on, right? But we have realized, the WHO has realized, with the based on evidence which has accumulated over the course of time, that these patients are not behaving like carcinoids. Rather, they are behaving, many of them are behaving more like adenocarcinomas of the appendix. And these tumors probably are adenocarcinomas with only neuroendocrine differentiation, right? There are so many tumors which can have a neuroendocrine differentiation. That doesn't make them carcinoids, right? So that is how like the new terminology has come, and there will still be debate about this terminology. Whether it withstand the test of time, we don't know, right? Based on the coming 5-10 years, we will know that if this has progressed to another entity, or maybe it will merge as a new one entity as appendiceal adenocarcinoma, goblet cell variant. That can happen, right? So I think that's a very valid question that you have asked. I don't think that I have an answer right now. Maybe time will have the answer. Thank you for that.
So, Dr. Rifat, I think it is quite late in India, and you have shown us so many examples. It was an excellent presentation, and you also gave us multiple scenarios which we can have during our practical evaluation of those slides. And now it is time to thank you from the moderators, myself and Dr. Rajni Jadhav, my colleague, and from the whole department, from the chairperson, all the organizers, and especially Dr. Venkat Iyer, who takes extra effort, and all the organizing team to organize this nice academic session. And we hope you also will be like to join us in future courses. So thank you so much.
Thank you so much, Prasajit, and thank you to the entire team at AIIMS. It's always a pleasure and a privilege to talk with you all, and thanks for this opportunity to me. Thank you so much.
Thank you, sir. Thank you. Good night.
So are we staying in the meeting or?
We